Thanks so much, Sarah, and thank you to you and to Scotty and to Jim for the invitation to join you in this KCNQ2 Cure Summit. And I wish we were all together in person. Much more fun being together, and there are a whole lot of other benefits in terms of talking around the disorder and how we can take it further that we miss by not being in the room together, but hopefully that will happen next time. And I'd like to thank all the fantastic families that have worked with me in my work with KCNQ2. Now, as you said, you gave me a great title for this talk, which is KCNQ2, Developmental and Epileptic Encephalopathy, our 10 years on and what have we learned? And we've learned a great deal, and I think the program reflects so many of the leaders in the field. So over the next 2 days, you're in for an absolute treat. Here are my disclosures. So let's just start with the basics. And what do these array of numbers or letters, as you just mentioned, mean? Well, the K stands for potassium. It's the chemical symbol for potassium. CN is simply channel. Q is the subfamily Q. And this gene is the second member of the Q subfamily of the K channels, of the potassium channel. So we started 10 years ago with the KCNQ2 epilepsies, and we realised at that time that there was the mild outcome and the more severe outcome within this, a spectrum, if you will. And the more we know about genetic epilepsies, the more we realise that they're all a spectrum, and you have to start to understand that. And now we need to unravel, why is there a spectrum? And that's the next, most exciting thing that we have to really start to grapple with. We knew already, before we found KCNQ2, Developmental and Epileptic Encephalopathy, that it was the cause of a rare familial neonatal seizure disorder with very good outcome. And it was also sometimes caused just a single patient, a single child in a family, when that child had a new mutation in that child, so there was no family history, but often it was familial. And then this work was the beginning of understanding that it causes a very significant developmental and epileptic encephalopathy. Now, I was just reflecting, getting ready for this talk, about what we're missing by being virtual. It's very easy. You can roll out of bed at 6 a.m. as we have this morning, but you actually miss one of the most important things about conferences, and that's going to dinner and chatting. And that's when I met these two unbelievable Belgian adult neurologists. Peter de Jonge was the wise father, and we sat there at Verona, actually, at a Dravet conference. And I told him about this intriguing finding I had in a beautiful little girl and her dad. And her dad had benign familial neonatal seizures with some ongoing seizures into adult life, very normal. Seizures had settled down by the time he was mid-30s or early 30s. And then he said, we've seen this too. And that began this study in which we were senior co-authors together. And the amazing Sarah Weckhausen came along and really ran the study as, I think, part of her PhD from memory, now many years ago. The essence of this is that it is a neonatal onset epileptic encephalopathy. And what do those words mean? Well, the epileptic encephalopathy refers to where the child has ongoing epileptic activity, and you can see at the back of this slide I have an EEG with every single second that child has a epileptic activity. And that epileptic activity, in addition to the seizures, contributes to that child not being able to learn, often quite significant behavioural problems. And this is more than you'd expect from the underlying pathology of the brain. Mostly these children have frequent seizures, often many types of seizures, and the critical issue behind the concept of an epileptic encephalopathy is that the child's development slows, or in fact the child regresses, goes backwards and loses abilities. So to look at that in picture form, here you see a little girl who I met at 22 months of age. She was having tonic seizures every 5 minutes when I met her, and she had very frequent epileptic activity. Her development had never been normal, but she lost the skills that she had, and she had SCN2A, this little girl. Now, why does this whole idea matter? Well, the idea is important because if you can stop that process of epileptic encephalopathy, you can improve the long-term outcome for that little baby or child. So if the child has a structural abnormality, and here you see multiple tubers or malformations of the brain in a child with tuberous sclerosis complex, if you can figure out which of these tubers is actually causing the seizures, epileptogenic, we call that, you can actually resect that tuber and you can stop that process of this barraging of the brain with epileptic activity. Now, equally, it's really important if the child has a genetic basis for their epileptic encephalopathy. And we now find the genetic cause in more than 50% of children. And here you see the potassium channel involved with KCNQ2 subunit. If you can make a diagnosis of KCNQ2 developmental and epileptic encephalopathy, and if you can use the right drugs such as sodium channel blockers, carbamazepine or phenytoin, for example, you can actually improve the seizure frequency, hopefully stop this very severe developmental impact and improve the long-term outcome for that child. In the later classification of the epilepsies that we brought out in 2017, we expanded this term of epileptic encephalopathy to the term developmental and epileptic encephalopathy. And here you see a little boy with KCNQ2 encephalopathy at the age of 4 years. The reason for changing or expanding the term was because we realized that many of these genes actually cause developmental slowing in their own right. So KCNQ2 can cause developmental slowing or just intellectual disability, and I'm going to talk about that a little bit more later on. But on top of that, many of these babies present with very severe seizures in the newborn period, and they have this epileptic encephalopathy, often with multiple seizure types, very frequent epileptic activity on their EEG, and this means that they can't develop. So how do you tell if it causes developmental slowing? If it begins in the first week of life, you can say, how do you know that the child was slow to start with? That is impossible to tell really, but as it emerges that KCNQ2 causes just a developmental encephalopathy or intellectual disability, you have evidence that an abnormality of this gene causes developmental and epileptic encephalopathy. The other important point here, which is illustrated by KCNQ2 very clearly, is that the seizures can stop, such as in this little guy who's 4 years old, when you can see him here, and his seizures stopped at 2. But as you can see, he has profound impairment with cerebral palsy. He doesn't have autism spectrum disorder, but he does have profound intellectual disability. Now, he went on when he was about 8 to develop seizures consistent with Lennox-Gastaut syndrome. So we know that one epilepsy syndrome can evolve into another. So within the developmental and epileptic encephalopathies, we have a host of different syndromes that we know very well. The best known ones are Lennox-Gastaut syndrome, infantile spasm syndrome, previously known as West, Dravet syndrome, just to name a few. There are other rarer ones, some of which begin early in the first month of life. And specifically here, we're interested in Ohtahara syndrome. And then there are others that are more focal in nature. But there are a whole lot of other children that don't fit into one of these neat little boxes, and they're in this blue sea around it, and they may begin under 3 months of age, in the early infantile group, in infancy between 3 months and 2 years, or indeed at any age. So I showed this, I think, at the last summit, which really reflects where we started this story with the developmental and epileptic encephalopathy that we described together with the Belgians. And you can see here, I like to use my puzzle idea to get at the complexity of the disorder. It's not just one feature, you need a whole host of these different features that together make up the puzzle of KCNQ2, developmental and epileptic encephalopathy. So very classically, this begins in the first week of life, and that's long been known with even benign familial neonatal seizures that onset is in the first week of life, or it might be deferred to what should be the first week of life if it's a premature baby. And the baby typically presents with very frequent tonic seizures. And here you see a little boy having a tonic seizure. He's pretty miserable, and you'll see it now. Watch his face and his arms. There he has a facial grimace and extension of all his limbs. And he doesn't like it very much. It's pretty awful. They go on then to develop focal seizures, tonic-clonic seizures, and in some cases, epileptic spasms. And here you see a little baby. Watch the baby's left arm, and you can see the baby is having jerking of that left arm, which is a focal clonic seizure, we call that. And it's the audio you can't hear, but the mum says it's been going for about 3 minutes and the baby's getting some oxygen. And these are also really terrifying for parents to see in their beautiful baby. Now, the next type of seizure is a focal impaired awareness seizure. And you see in this little boy that he has head and eye deviation, the eyes deviated up and to the right, some little oral movements. And now I think the seizure's finished and you can see his beautiful little smile coming back. But there he was having a focal impaired awareness seizure. And now he's responding to his mum rather beautifully. Now, with KCNQ2, developmental and epileptic encephalopathy, impairment is often severe to profound, but there are milder cases, and they may have autism spectrum disorder. And autism is an interesting diagnosis. It's really a behavioural presentation. If you have profound impairment, it's very hard to make a diagnosis of autism spectrum disorder, and I'm not sure how useful it is. If you have moderate to severe or mild to severe impairment, it can be a very helpful way of understanding what the child is interested in and how they respond to you. In terms of development, these children typically have hypotonia, which means low body tone, spasticity, which is in the limbs where there might be increased tone, and they may have dystonia or abnormal tone. The EEG shows a very classical burst suppression picture that you see here. If you see that on a newborn baby, it's very concerning. And you have this burst of epileptic activity and then a suppression of flattened EEG and then a burst again. And it can also show this multifocal appearance with discharges from different regions of the brain. These sorts of EEGs, as a neurologist, make your heart sink because you think, oh dear, this could be very serious. And then obviously for KCNQ2 developmental and epileptic encephalopathy, you have to have an abnormal variant, a mutation. We now use the term pathogenic variant, but it means the same as mutation. And they usually have a missense mutation, which means the genetic code has just got the code wrong, typically by just one letter, and you get the wrong amino acid, which is the building block of the protein. You get the wrong amino acid put in, and so the channel doesn't function properly. And in some of the patients, the seizures stop by about 4 years of age, but in many still they do not. So that's the background to KCNQ2 developmental and epileptic encephalopathy. We have these two major groups, the mild self-limited normal outcome group and the more severe group. But what have we learned in the last 10 years? Well, we've learned that KCNQ2 encephalopathy is much broader than we initially thought. And this is normal in medicine, that you begin by understanding a small group of patients and you describe that. And that's exactly what happened with Dravet syndrome. And then you learned that the actual spectrum of presentations within the encephalopathy is much broader than you thought. And encephalopathy simply means disorder of the brain. That's all it means, nothing special. So this is a disorder of the brain due to an abnormality of KCNQ2. And we started with this disorder I've just described to you, but what's come to light in very recent times is that KCNQ2 can just cause intellectual disability with or without autism spectrum disorder, which is the same as saying the child has a developmental encephalopathy, a problem with their brain causing abnormal development, but without the epilepsy. And I guess it was unsurprising to find this, important but unsurprising, because the more we know about the genetic determinants of these groups, of this group of diseases, the more we realise that there's huge overlap. So if you look at the genes for intellectual disability and the genes for severe epilepsies, there are many that cause both presentations. Similarly for autism spectrum disorder, and a whole range of neurological impairments. So the more we know, the more overlap there is, and it makes it interesting but also intriguing to ask, why does one child have the epilepsy and such severe epilepsy and another one not? So let's just think about the developmental and epileptic encephalopathies further. And I've already talked to you about this paper, 10 years old now, that overlaps the Ohtahara syndrome with the early infantile developmental and epileptic encephalopathy. And that came out of that first study, but now there have been many much larger studies looking at this, many led by Sarah Veckhausen actually. And but also there are lots of other people contributing to our understanding of this group of diseases. And then it was shown by John Millichap and colleagues that it could also cause infantile spasm syndrome, or West syndrome is the old name for that. And these two were very different presentations, with the first two being due to loss of function. So the channel doesn't work properly, loses function, being associated with missense mutations, and infantile spasm syndrome being the opposite, causing gain of channel function, but a different sort of missense mutation. So back to my picture of all the epilepsy syndromes that we know and know very well and know how to recognise these children, and which are now implicated for KCNQ2. Well, there you can see the picture is increasing in terms of the very severe epilepsies. So I wanted to talk about some of these newer players to the table. The first one is a very severe syndrome called epilepsy of infancy with migrating focal seizures. And we did this large study, which was, as you can see, many international collaborators, where we looked at 135 children with this very rare syndrome. The hallmark of this syndrome is in this picture, where seizures migrate from one half of the brain to the other half of the brain. And in this syndrome, this is the same baby at two different ages. And I'm hoping both of these videos will play at the same time. You never know your luck. And you can see with this baby that the baby has involvement of different arms in different seizures. Now, actually, what you do need to see in this is that it progresses from one side of the body to the other, but that doesn't always, you don't capture that on a video, but you can see here, same baby, two different videos, one involving the right upper limb or right arm and the other left arm. And this is the idea that both sides of the brain are involved. In this large collaboration, we looked at 135 patients with this extremely rare disease, and they all had to have this fundamental point about the migration between hemispheres, between the two sides of the brain of the seizures. They had to have onset under 6 months of age. And these babies usually have a crescendo pattern where seizures get more and more frequent, such that they're occurring eventually basically all the time, and they typically end up in the intensive care unit. Their development may be abnormal beforehand or normal, but usually would be abnormal, and they lose their skills, and they typically end up with profound developmental impairment. Now, we found the 33 genes, so each gene is a different disease, if you will, but there were 33 different genes that could lead to this particular syndrome. And 3 of the genes had onset. If the baby had one of 3 genes, I'll say it a different way, they had onset of seizures in the first week of life. And guess what popped up? KCNQ2, which isn't surprising really, because we know it's a first week of life type of gene. And we had 4 patients out of the 135 with KCNQ2. With a median onset of 3 days of age, which goes well with what we know about KCNQ2. Interestingly, out of the 135 patients, there were 7 who had a better outcome, and they included 3 of the KCNQ2 children, 3 out of the 4, which is pretty amazing. 2 had been seizure-free for periods of at least a year, and developmentally, 1 was actually normal, which is amazing and fantastic to see that can happen. And 2 had mild to moderate intellectual disability rather than that severe to profound, which we often see with the more classical form of KCNQ2, developmental and epileptic encephalopathy. So if you have a look here, you see the genes involved in this particular syndrome in these 135 patients. And I guess the take-home message from this, apart from a whole lot of word letters, alphabet soup, is that half of the patients have a dominantly inherited gene, which means you only need a single bad copy to have the disease, and they're shown in blue. In brown, you see a quarter of the patients have genes which are called autosomal recessive, which means you need to have 2 bad copies, one from mama, one from dad, to have the disease. And those 2 bad copies might be the same bad copy. That's more likely if your parents are blood related, or may just be bad luck, or they may have 2 different bad copies of the gene, one from mama, one from dad, and then they have this brown recessive disorder. And the few in green are X-linked, which means it's on the X chromosome. And I'm happy to expand on that if anyone wants to know more. But interestingly, we've still got a third to go. We haven't solved them all. And the reason for showing this, of course, is that KCNQ2 is there, and you can see out of our 135, it was probably the 3rd most important player, or 4th, sorry, I can count, the 4th most important player. Now, the other important syndrome, which was described by John Millichap and colleagues back a few years ago now, 4 years ago, was that West syndrome, now being called infantile spasm syndrome, could also arise due to KCNQ2. And I've got a little baby here, not one with West, but showing you the typical pattern of spasms, which are these, they can be flexion or extension episodes of typically both arms, and the legs are involved in the face as well. And these go on maybe for 3 minutes, maybe for 20 minutes, depending on the child, these clusters or series of spasms. Often they take a while to be diagnosed, but once you start recognizing them, they're very identifiable. Now, that was originally found in 4 patients with onset at the typical age of infantile spasms of 4 to 6 months. And importantly, these children did not have preceding neonatal seizures. And these children were studied at the ages of 3 to 11 years, and they were seizure-free. So the seizures was not their big problem, but the severe impairment was. And they shared, in fact, a recurrent mutation, a missense mutation, which was de novo, which means it was new in the child, not present in mum or dad, dominant, which we know is the case for KCNQ2. But interestingly, they all had the same mutation, causing this very, very distinctive picture and likely to be gain of function. So what do we know about the epidemiology of KCNQ2? And this is from my friends Samir Ziberi and Joe Simons in Scotland. They did a beautiful 3-year study, study of children presenting up to the age of 3 years in the whole of Scotland with seizures of any sort. And they, not febrile seizures, I think, but they were long or recurrent febrile seizures, but not regular febrile seizures. And you can see here that number 3 player is KCNQ2, but it's number 2 in the developmental and epileptic encephalopathies. And they found that KCNQ2 had an incidence of 1 in 17,000 live births. So that starts to give us a handle on the frequency of this gene from an epidemiological perspective. Now, of those cases, most of them had the benign familial or non-familial neonatal seizures, and only 2 out of the 10 were the developmental and epileptic encephalopathy. Now, we've also done some epidemiological study of this based in our state of Victoria, in Red, in Australia. And I did this study with my PhD student, Catherine Howe, where we looked at severe epilepsies beginning under 18 months of age. But the definition for the inclusion criteria meant that we didn't capture all the developmental and epileptic encephalopathies, and in particular Dravet syndrome is not included in these numbers. What we got, though, was an incidence of 1 in 2,000 live births for this group of diseases, which is quite scary when you think how frequent that is. And if you do include the older developmental and epileptic encephalopathies, such as Dravet or Lennox-Gastaut, etc., it's probably really double that. We found the cause in about 67% of the patients, and more than half had a genetic cause. In addition to the 54% there, some had malformations, and they also were genetic. And so looking at that data set, 2.6% of our developmental and epileptic encephalopathies were due to KCNQ2. So that gives you a bit of an idea of how frequent KCNQ2 is with your cousins, as Sarah likes to say, the Dravet children and the all the other genes that we know for this group of disorders. But let me tell you about something else. This is a beautiful little boy that I met on Zoom only a week ago for the first time, and his rather amazing parents. And his mother was actually worried about him from when he was 8 months old. Now, she's a psychologist who's an expert in autism, but she brought her own clinical skills to bear, and she was concerned that her beautiful little boy might have autism. He went on to have quite significant delay, not walking until just a month ago. He had complex babble, which is like ma, 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 and da, 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 and ba, 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 when he was 8 months old, but he lost that with the regression associated with the autism. And he currently has no words, but will follow a single command, loves water, as you can see here, and thank you to the family for allowing me to show him. And he was extremely active, as I even observed on Zoom as the parents ran around the room chasing him. He was rather gorgeous. He also has some stereotypies, such as rocking and hand flicking and those sort of things, and of course sleep is not good. But interestingly, he has had absolutely no seizures. And he has a de novo, so new in him, missense variant of KCNQ2. And it just happened that Mary and colleagues, a French group, had just published 4 patients with KCNQ2 without epilepsy. Intellectual disability was mild to severe, mild, moderate and severe across the 4 different children, with speech more affected than motor skills, which is pretty usual for those with intellectual disability. They did have hypotonia, which I'm sure many of the parents will recognise as part of KCNQ2. 2 of the 4 had autistic features, as our little guy does. They did not have stereotypies. Although none had epilepsy, one had had 3 febrile seizures, 2 at 9 years, some at 2 years and at 9 years. Strictly 9 years is a bit old for febrile seizures, but nevertheless had very mild seizures. Despite not having seizures, their EEG showed epileptic activity, multifocal spikes, and their MRIs were normal or showed delayed myelination. And delayed myelination is very non-specific. It's something we see in many children with developmental delay or intellectual disability, that the myelination of the brain, which is where the white matter has a coating of myelin put on it that helps conduction within the brain, that is often abnormal in children with developmental delay. So in this study, they looked at the mutations, and they had, these 4 children had 3 different missense mutations. So one was a recurrent mutation. Now, interestingly, in 3 of the 4 children, it involved one specific amino acid, 144, and that had already been reported in the infantile spasm syndrome that I just described from John Millichap, has subsequently been reported in that syndrome, which we know is a gain of function mutation. And I've put John Millichap's particular infantile spasms mutation here in blue, but these children are shown in red. And on the left, you see all the mutations associated with the self-limited neonatal epilepsy, and on the right, all of the mutations associated with KCNQ2. And you can see really there's nothing about the location of the mutation in these children with intellectual disability that tells you that they're not going to have epilepsy. So this is quite intriguing. And whereabouts in the protein does it tell you what's going to happen? And this work has been really done by many groups, but I've taken the figure from this intellectual disability only paper just to show you. And you can see here that truncating mutations where the protein isn't made is associated with the mild form, the benign or self-limited neonatal, familial or not neonatal epilepsy. But as well as that, we have the much more significant missense mutations associated with the encephalopathy here in the fourth segment of the protein, in the linker between the fourth and fifth segment, and also in the sixth segment of the protein. So we know there are regions where if there are mutations or pathogenic variants found, you are more likely to have a severe outcome than a mild self-limited outcome. Okay, I just wanted to move a little bit to genetic counselling for families with a child with KCNQ2, developmental and epileptic encephalopathy. And this is really for all the new parents who are present, because I think this is really important for you to know about. And as I've already mentioned, this is a dominantly inherited gene. If you have the abnormality, you have the disease. But normally it's new in the child and not present in mum or dad. So if they have one child with this disease, then they're given a very low recurrence risk. They say, we've checked you, mum and dad, it's not there in you. Your chance of having another child with this KCNQ2 encephalopathy is extremely low. But is that always the case? And here you see two children, they don't have KCNQ2, they have another gene, but they have a developmental and epileptic encephalopathy, a 2-year-old boy and his 4-year-old sister, and neither sit or walk or talk. And you can see here the parents are fantastic parents who do everything. But by the time you have a second child with a disease, you know it has to be genetic. 2 affected children and unaffected parents. One of the parents must carry this disease, and one of these parents must be mosaic. And mosaicism is beautifully shown by this Australian Aboriginal painting, where you can see a mosaic, 2 different populations of cells. You might have your mutant cells and your normal cells. And how this works is if you're a normal person, but you have this second population of abnormal cells, if they happen to be in your gonads, be that your eggs or your sperm, if it goes into making that baby, you'll have an affected baby. And in this study that we did with Heather Mefford and Candace Myers, we looked at 120 families with children with developmental and epileptic encephalopathies, and we looked at their parents of the children, where they thought that the parents did not have the mutation, but we looked at mum and at dad 200 times for their child's mutation. All of them had, there were 33 different genes represented, but each child had an abnormality of 1 gene. So what did we find? We have found that 8% of our patients had a parent who was mosaic, which means that that family may have an increased risk of having a second affected child. And here you can see the families that we found them in, half were in mums and half in dads. Importantly though, if there was a higher percentage of mosaicism, the parent was more likely to have seizures. They could have just been febrile seizures in babyhood, or they could have been epilepsy. And just note this, that one here was KCNQ2 in a mother who was 3% mosaic, and therefore at risk of having a second affected child. And while I was preparing this, I remembered the original family I talked about at the beginning of this, where dad had epilepsy and he was actually 30% mosaic. So this is important for the new parents who are new to this world, that the parental mosaicism has been underestimated, and that if you have a child with, and you are thought not to carry the mutation, there is an increased risk if you could have this very low level of mosaicism, and you can ask your geneticist to test for that specifically. One of the red flags is if either of you have had seizures, and if you have a higher percentage of mosaicism, you're more likely to have epilepsy. So what about the long-term outcome? Well, we know that 70% of children have a poor long-term outcome. They can be very happy and beautifully interactive, as you see here, but they're non-verbal, not able to walk, often cerebral palsy, although the seizures often resolve in 25%. Now, we are seeing some movement disorders. There's a lovely paper from Dedick and colleagues describing myokymia, which is very subtle little muscle flickering. There's a child with chorea and myoclonus. You can see tic disorders, such as this young lady, which were triggered by antipsychotic medication and a range of stereotypies. We start with seizures, but that's not where it ends up. And I know you've got lots of fantastic talks coming that will deal with issues such as sleep, speech problems, motor problems, autism, gut problems, behavioural problems, and of course, an increased mortality risk. And in the last few slides, I just wanted to touch on treatment. I know you're going to have a lot more about it at this meeting, but from the day you get a genetic diagnosis, we should be tailoring our anti-seizure medicine. And this is from a paper that I published with my Italian collaborators a few years ago, where we looked at and showed that both carbamazepine, tegretol, and phenytoin dilantin were very good for patients with KCNQ2 developmental and epileptic encephalopathy, often causing seizures to be controlled and allowing the child to get on with development. But is it enough? The answer is no. We need targeted anti-seizure medicines. And of course, there was a lot of promise with retigabine, or ezogabine as it's known in the US, a targeted potassium channel opener. We know it works in focal epilepsy. It came off the market because of its blue discoloration, but I know it's now being looked at again for KCNQ2, which is very exciting, with tailored trials that we're very excited to be part of. But what about the big question? What we really want here is a precision medicine that targets all aspects of KCNQ2 encephalopathy, not just seizures. We want to make sure development is normal, all those other features are improved, or comorbidities. And that is the hope, I think, of gene therapy. I'm really optimistic about that. I know you're going to have some fantastic talks about where that's headed, and that's our great hope at present. So I'd like to conclude by thanking the fantastic families that contribute so much to this work and who we really want to help. And this is taken from, I think, the last summit, and you can see Scotty there. Thank you very much, and Caroline too, now I see. And I also want to thank the fantastic group of people that I work with and my international collaborators, and most importantly, the patients and families. Thank you for your attention.
Thank you so much, Ingrid. And I wanted to let you know that your presentation has been heard by people from all around the world. I'm looking at the chat, and I just want to mention some of the places that people are tuning in from today. For example, we have Marcos from Mendoza, Argentina. We have the Vice President of our European KCNQ2 Association joining us from Italy. We have people from Canada, several here from Melbourne. Shout out to the folks from the home crowd, and Canada. We're also, and then of course many states in the United States, England, from Argentina, somebody from Puerto Rico who's now living in Florida. I am definitely not giving you everybody, but what I wanted to say is that what we understand. Oh, and I'm Ingrid, is that this is, as we know, a condition that affects people around the world. And it's fascinating to hear the latest from you now that we are 10 years on. We do have a couple of questions that are coming through. The first one I wanted to ask you about is for one of our family members who says, my son is loss of function and was diagnosed with West syndrome. And you talk some about that. I know there are numerous others with this, infantile spasm syndrome with loss of function. I'm curious on your thoughts about that. So I'd love for you to expand a teeny bit on West syndrome.
Thanks, Sarah. Really important question, because physiology, and when we talk about gain of function or loss of function, it depends on very high level physiology studies, which are done by people who are scientists who work in the laboratories looking at how the channel works in the cell, And then they look at it often in an animal model, in a mouse, or they might look at it in a zebrafish. There are many ways you can ask these questions. Now, there are also, the more you know about the physiology, the harder it gets and the more complex it gets. And it may be that it makes the channel open too fast or close too slowly, or it may be that the channel's in the wrong part of the cell, or it might be the wrong cell. As in, it might be that it's not working well in a cell that inhibits seizures, or it might be working and therefore the other cells can take over, the excitatory cells, or it might be that it's making the excitatory cell work too well. So the question really is around spasms. Do they always cause gain of function or loss of function, or both? And the answer is, I suspect both, which is what you have read. And that will depend a bit on how it's tested, which bit of the testing they're looking at. So there are many ways a physiologist can look at a channel, and they may all show different things. And quite often they'll show a mixed picture, some with gain and some with loss. And then you end up going, and I think that just speaks to the complexity, and it's not quite as straightforward as we would have it.
Ingrid, I have another question for you, and this is one that still comes up in the parent group, and I know you've got a really strong answer on this, but a lot of people ask to what extent developmental issues are caused by the seizures versus the mutation itself, and also if there's any relationship between the seizure activity and the extent of the developmental issues. So I know that's a crucial area for people to understand that this is coming from the gene, from the KCNQ2 DEE. Can you elaborate a little bit on that?
Well, I hope that's one of the messages you got from my talk, which is really it's hard to pull that apart. But we do know that many of the children, they're born within a few days of life, they're having very, very frequent seizures. And we know that with that, the child's development often, if they were more normal, they'll lose that normal tone and they'll be less like a normal baby. So we know that lots and lots of seizures do affect the way the child develops. But the interesting point about these new cases where they have just intellectual disability without epilepsy shows you very clearly KCNQ2 causes developmental problems in its own right. And then how can you say how much is, it's really how long's a piece of string, and it's very hard to say that it's all the seizures or it's just the development. And it's definitely a combination of both in the children with developmental and epileptic encephalopathies. Interestingly, infantile spasms is always an epileptic encephalopathy, always, because you have this very abnormal EEG called hypsarrhythmia, which is the signature of it. And so these children with infantile spasms begin at 4 to 6 months of age. And they may be normal beforehand, in which case it's just an epileptic encephalopathy, or maybe they're abnormal, and then it's more likely to be a developmental and epileptic encephalopathy.
Right. And so if we follow on from that, I mean, it was fascinating in your talk. When we first spoke years ago, I mean, there was really an open question as to whether or not KCNQ2 could exist without seizures. And now, as we see from this latest research, it can. So is that really a sign of how the science is just kind of barreling forward, Ingrid?
Yeah, look, I think it really reflects the advances in gene testing technology called next generation sequencing. And with that now, many patients are getting access to early testing, often within days of life, and children certainly with intellectual disability or developmental delay get testing, and so that they're being picked up now. And I think there are lots more surprises for us around the corner as these group of patients with these disorders increase over time. We're going to understand more about these very different or unusual presentations.
I have one last question before we let you go. In terms of that, tricky picture of the development and the seizures and that kind of unpinning that, how important is seizure control in terms of development and for preventing the potential of seizures to do additional damage?
I think it's critical, really, really important, and I think it needs aggressive early treatment. And even back in 2015 in the Italian paper I mentioned, where we showed that the right treatment could get the seizures under control, it allows the child then to get on with developing and doing what they should do. And I know anecdotally in Australia now people are being treated much more aggressively and the outcomes are looking better, which is a wonderful, wonderful relief.